The Mental Health and Addictions report talks about moving services for things like suicide prevention into the communities. What does that mean at a practical level?
Hospitals, while necessary, are the most expensive part of the system. And if you get the balance of those two things wrong towards more hospital-based, you're going to end up with primary care services and community care services which are under-delivering. And if you think about the consequence of that, if we intervene earlier and closer to the person's home and community where they live, we can get some really good outcomes for less expenditure. And if we don't do that, we end up with predictable growth in volumes going to hospital.
What do we need to see for suicide rates to come down?
Well, okay, so that's a really interesting and complex problem, but we're not going to solve it by having more hospital services. Not in any significant way will that decrease suicide rates in the community. Specifically in mental health, you think we've ring-fenced funding for secondary care, hospital-based mental health services, really expensive, really important, and aimed at about 3% of the population. And actually something near 20% of the population will have a mental health need. So it'd be smart if we spent an additional amount of money to support the 5, 10, 15% of the population who have mild to moderate mental health conditions and needs and concerns. What we'll see is a shift towards more community care and primary care and services available for people to get some help earlier in that journey. If we do that well, then we can help to keep the 3% part of that well managed and costing less to the system.
Why hasn't that happened already?
Well, these are institutions which have for a long time dominated the planning and clearly dominated the funding. There's a lot of work to overcome that. I mean, culturally they are going to be embedded in funding their own institutions.
So are hospitals gobbling up our health dollars?
Yep. Hospitals are gobbling up our health dollars and we can do better.
So they're all just a bit backwards?
Well, okay, so it's a structural issue in which we've got district health boards. It'd be pretty hard to get elected to a district health board if you said let's have a smaller footprint of a hospital. It's not that popular as a policy. It is rationally a really good idea, but in the way that we've structured district health boards, it's actually quite hard to get a platform for change. So I think the real push is going to come from outside of the DHBs.
What about your hospital counterparts? What conversations have you had with surgeons or any of the staff working there? Yeah,
we don't engage formally with the hospital specialists. I think in my work as a GP, I do get to engage with specialists, and many of them see that there's huge benefit to be gained by having appropriate primary care services.
What about Māori health? Where does that fit into the picture?
So Māori is a really important population to be looking at, and I think that comes from the sort of treaty rights. It also comes because we've got inequities, i.e. we've got health differences which shouldn't exist, which can be fixed. So there's an ethical imperative to do that. But Māori are not the only ones who have inequities, and I think we can see that for Pacific populations and we see it for some other populations as well. And so in addressing inequities for Māori, we are very likely to discover how to fix inequities for other populations, and we should address those.